Good evening, everyone. Welcome to our newest episode of the UT Southwestern Science Cafe. We hope your summer is fantastic and that each of you have stayed healthy and in good spirits. We're glad to be back on the air with you. And for our regulars, we're glad to see you. And for our new guests, we are so pleased to meet you this evening. My name is Jenny King, and I lead the public affairs team at UT Southwestern on behalf of my new public affairs colleagues, Charlandra Thompson and Joya Lang, as well as our guest speakers, Dr. Sasha Alick Lindstrom and Dr. Elizabeth Davenport. Thank you for joining us tonight. Science Cafes are online conversations where our speakers take you on deep dives into science topics. We want to have fun while we learn. Our format is casual and interactive, and we encourage you to ask questions and engage with us during the program. This evening, we will be discussing magnificent brains, mapping the path to a cure for seizures. Before we get started, we do have a few technical matters to briefly mention, so here we go. We are recording tonight's program and also live streaming it on our UT Southwestern Twitter page. Please go ahead and mute your microphones to help with everyone's audio clarity, and just unmute yourself if you are called on to ask a question. We encourage you to utilize the chat feature to list questions for both doctors. We did receive a number of great questions in advance, and we will also reference those. We will start Q&A at the conclusion of both presentations. Joya will be facilitating Q&A. Charlandra and I are monitoring the questions chat box. Finally, just a reminder, while we cannot answer personal medical questions, we would love to hear from you with your general questions about epilepsy and the MEG. And with that, I'm very pleased to introduce our presenters. My script went away for me. Dr. Sasha Alick Lindstrom is a UT Southwestern triple boarded neurologist and chief neurophysiologist and epileptologist for the MEG program. She specializes in the diagnosis and care of patients with epilepsy, using the latest medications and treatments to find the best options for each patient. Dr. Elizabeth Moody Davenport serves as the technical director for the Magnetoencephalography, or the MEG, Center of Excellence here at UT Southwestern. She will share about harnessing the power of this technology for diagnosis and treatment with pinpointing.
Yeah, it's on magnificent.
Where a patient's seizure originates in their brain. Joya is pasting bio links for both doctors into the chat, and please click through to read all about them and their amazing extensive work. To you both, welcome to Science Cafe, and to Dr. Alick Lindstrom, the virtual podium is yours.
Awesome. Hello, everyone. Thanks for joining us. Bear with me, my voice is not the best tonight. It's those allergies. Let's see if this will advance.
I just needed to switch over. There you go. Sorry.
There we go. Perfect. So I will be covering more of the clinical part of epilepsy. So we'll cover the basics, the medications, when to seek higher level of care, like at a center, a level 4 center, like our center here at UT Southwestern. What other options we have and what the pre-surgical process entails, and where we can go after that, either surgery, lasers, and all the different neurostimulation devices that we have available, which are currently 3. Let's start with some definitions in terms of an epileptic seizure. So it is basically a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. And so epilepsy is a chronic disorder, the hallmark being recurrent unprovoked seizures. So a person is diagnosed with epilepsy whenever they have 2 seizures more than 24 hours apart, or a seizure and higher likelihood of having a subsequent seizure, either by EEG or suspected syndrome or exam or any lesion in the brain or whatnot. So for the purposes of simplicity in today's talk, we're going to talk about 2 major types. We have focal epilepsy, which was formerly called partial epilepsy. That can be focal with retained awareness, or focal with impaired awareness, which is formerly called complex partial seizures. and then the generalized epilepsy. And then the third category would be, you know, whenever you don't see the onset and you don't know which it could be unknown. So now you know what epilepsy is, right? Not quite. So what else do you have to consider whenever you have somebody in front of you and they say, oh, I have epilepsy, whatnot? So epilepsy is a lot more than just having seizures, right? It's keeping in mind all the potential triggers. You know, a lot of people talk about photosensitivity and like lights and whatnot, but really it's a lot more, you know, like if they miss meds or if they're sleep deprived or even stressed or any number of things. Everybody's different, right? And then how about medication? You know, whatever is good for this person is not going to be good for another person, or they can't tolerate it, which means they're not going to take it. And of course, they're going to have seizures, and they could have allergies to the medication or intolerable side effects, or, you know, if it's going to sedate you and you can't work or function, you're not going to take it, right? And for example, there's meds that you have to take like 2-3 times a day, and you're gonna forget a dose. I know that whenever I'm on antibiotics or whatever, I'll forget a dose. So
Yeah, I've done it.
so I mean, there's like 1-a-day dosing that you can take at bedtime and whatnot to help that, you know. Also financial constraints. There's no point in prescribing a medication that they can't afford. Like, I really, really, really dislike it whenever somebody comes to me from someone else and then they're like, oh, they prescribed this medication for me. And I'm like, oh yeah, it's the latest and the greatest, but it's very expensive. Of course, you haven't started it, you're not going to be able to afford it. I wouldn't want to pay for it, you know? Another thing would be sleep, not only the duration, but the quality of their sleep. Sleep is super important in epilepsy. You need to cover sleep hygiene, good quality sleep, make sure they don't have sleep apnea, because that'll lower the seizure threshold and can contribute to poor control of the disorder. Another thing is mood, anxiety. Those are huge comorbidities or things that go along with having a seizure disorder and living with seizures, right? And just mental health in general. It's always good to kind of inquire about that, because it's kind of tough, you know, to, you know, just bring it up in an appointment. So I just like to ask about that, and we actually screen for that as well, and we have a good team for that because it's pretty quite common, you know.
I say we have a specialized team here, right?
Exactly.
For psychiatry and epilepsy.
Exactly. Yes. And another thing would be, I mean, personal goals and values and family planning. I mean, we have a lot of young women who've been told, oh, I can't get pregnant or whatnot, or, oh, they told me I have to have a hysterectomy, when that's really not true. I mean, if you plan in advance, you can get them on the right meds, get them under good control, and make sure they're on folic acid, and just take the proper steps and get the right medication levels and test them and make sure that everything's in order to have a healthy, successful pregnancy and whatnot. And some people, it sounds kind of simple, but some people will actually just say, my goal is I want to drive. And like something that you take for granted as driving, and sometimes like I hate driving in traffic here. I mean, some people want to do that, you know, it's independence. You also want to ask if they're drinking alcohol or doing any drugs. And a lot of people will do that to cope with the mental health issues, you know, that they've been encountering, but that also will lead to poor seizure control and other health issues. And then make sure to cover seizure first aid, make sure the people around them know what to do in case of a seizure, have an education plan or any accommodations at work or in school or whatnot. And also ask them, like, do they feel like a warning sign or an aura before they have a seizure blackout? Because that can always help us determine like where in the brain the seizures might be coming from. And we use that to create the hypothesis of where in the brain they'd be coming from. And you've seen this in conference. So.
Yeah, it's really interesting. I've loved learning about it.
And the other thing is a seizure diary. people come in and I'm like, oh, how have you been since the last appointment? Oh, great. Have you had any seizures? Yep. I'm like, how many and when? I don't know, a handful. I'm like, how about that seizure diary? It's great. I mean, nowadays there's apps on your phone. You can write it down. I'm like, even bring me a little notepad, your phone, anything. Keep a little notebook. We give you like a little seizure diary too. So you can put down like I had a seizure, what was a trigger, any specific kind of details about it, you know, and you start learning if there's a pattern or any triggers or anything. And if you're a woman also, if there's any hormonal influence over the pattern of procedures, because that can also let us know we need to do any hormonal treatment or whatnot to control your seizure disorder. So there are over 30 seizure medications in the market nowadays. And unfortunately, even though we have all these options, all with their plus and minuses and side effects and benefits and whatnot, there's no evidence that we've gotten any further in controlling seizure disorders. There's still like a third of patients that will become refractory to meds, meaning they won't respond to meds. So there's a third of patients that meds will not work for. And that's basically what we specialize in here. And this is why I love this team and the multidisciplinary approach that we take here. So that third of patients is called, they're in a group called DRE, or drug-resistant epilepsy, right? And the proper thing to do is whenever you fail 2 or more properly chosen medications that are tolerated and everything, and you're still having seizures, I mean, once you go to the third and further meds, the chance that you'll be seizure-free alone on meds drops to like under 4% or so. So it's like slim chance. And we like those people to get referred sooner rather than later because we have better odds of controlling their seizures, right? And they don't take a hit like cognitively or memory-wise, mood-wise, whatnot. So you did a very good job, Jenny, in saying epileptologist, which is, you got both of them right, which is also known as a seizure specialist like myself. And it's basically a neurologist that specializes in the treatment of epilepsy. So all I do all day, every day is care for people with epilepsy and work on research and whatnot. And just basically my life revolves around epilepsy.
And read studies, don't forget this.
Yeah, we'll get to that.
We'll get there.
Yeah. And so basically it takes a lot of training. You finish school, high school, college, medical school, intern year, neurology, then you do neurophysiology.
How long is residency again?
4 years. And then on top of becoming a neurologist, then you do clinical neurophysiology and epilepsy. And so we know what we're doing. Yeah. So where can you find us? Where can you find me? Well, I wish this was a joke, but usually we're really in poorly lit rooms with no windows, staring at squiggly lines, and that's what my office looks like. But really, you could conduct internet searches, you know, make sure they're board certified and in the fields that I said. Epilepsy Foundation website, AES, academic medical centers. Just make sure that if you have failed 2 or more meds or whatnot, that you can be proactive and look for a center like us. So the PreSurgical Workup, we're gonna go over it. It's really complicated. We're gonna go over it super fast speed, but so EMU, the Epilepsy Monitoring Unit, that's the phase 1 monitoring. By that point, you've already had an EEG.
Yeah.
Okay.
And do we want to do the poll and see if they know
Yes.
what EEG is?
Let's see.
Let's see if I can do this.
Or we can start with that one.
Yeah, how many of you, so we'll do 2 polls at once. How many of you know someone with epilepsy? So we'll see what the prevalence in our audience is we're going to turn into epidemiologists for a second and study prevalence. Very nerdy joke. Yeah. Yeah. All right. Looks like we've got almost 80% coming in now. So I'm going to go ahead and share the results. And so it looks about 62% of the people here know somebody with epilepsy.
Yeah.
Yeah. All right.
It always like blows my mind how, I mean, the stats say like 1 in 26 people here will develop epilepsy in their lifetime. So it's pretty common.
I was really surprised when I first started working with you guys that how, like, it's not always that it onsets at childhood. I always thought it was something you were born with and you always had. But no, it can onset like even in people in their 40s and 50s.
Yeah.
Which was surprising to me when I first started learning. All right, so do we want to do, what does EEG measure? So it can measure electrical activity in the brain, the tech's hairdressing skills. It's very critical for them to have great ability to
They're
grade.
pretty good.
Yeah, and fast, yeah. Or the patient's aura. It looks like we're 100%.
Yeah,
they're too smart.
Yeah, they're smart.
They got our question. All right, so we'll go ahead and end polling. So 100% of you guessed correctly, or knew correctly. It measures the electrical activity in the brain.
Okay. So now we have that established, so we can proceed. So in the EMU, the epilepsy monitoring unit, you'll come in for phase 1 or scalp monitoring. We usually like to say you join us for 3 to 5 days, could be more, could be less. We have 2 of them here that we all rotate through, Parkland and Clements and whatnot, and they're fully staffed. You come in, we do the EEG, and you're in your own room and you have video on you the whole time. And we try to trigger seizures safely, right? And you have an IV and we can stop the seizures and whatnot. And the whole goal is being able to witness firsthand, like what your seizures look like, what your brain activity is doing during them, and basically study to see where they're coming from to be able to control them.
There's a lot of tech that goes into that too. Like as an engineer, I was really excited because it's you have video that's time locked with the signal from the brain. It's really cool.
Yeah. And neuropsychology testing, we have a great team of neuropsychologists that help us, tease out like how their memory is, how their cognition is, how all their different functions are, and they weigh in whenever we need to discuss each and every case. Just so we make sure that there's concordance and we know like what functions in the brain are intact or which ones are like kind of deficient, and make sure that it kind of lines up. The functional MRI, which I'll show a picture of, it shows basically function in the brain, just to keep it simple. And we want to control the seizures, but we don't want to eliminate function. So we don't want to touch adult cortex. So this will help us determine, where language is, motor, and other modalities. So that's going to be very key. A PET, it's been shown that areas that appear hypometabolic or like down in terms of the uptake are areas that tend to generate seizures. So we kind of just put it all together, like all the multimodal imaging and whatnot, and what we've seen in the EMU and what we see in the high resolution MRI with thin cuts, and the MEG, which you will talk to us about very, very soon. And we meet every week, one of our many meetings, and we put it all together and we create a plan. So.
Oh, I think
I broke
out of it. No, I broke it. There you go.
Okay, so this is just a generic picture. I mean, it's on our website. It's kind of what it looks like. There's Dr. Hayes, our fearless leader, one of the 12 of us in our team, epileptologist, and that's what it kind of looks like. The patient's there, bandaged up. One of our many great techs sets it up. We have a screen there. There's a video, whatnot. And you can have a family member stay or not. Things are a little different now with COVID, but like everything's in flux now. So
Yeah, it's all
I
different.
can't keep up. And there's kind of like the control station, like everybody's watched day and night. Not in the bathroom, but day and night, make sure that we're aware whenever they have seizures, either electrically or clinically or whatnot. And they also give you a push button so you can push it, like if you feel like an aura or like you might have had a seizure or whatnot. And people like rush in, they help you and marks a study, and it helps us kind of analyze it. And they can test you, they can do thorough testing, which kind of helps to see if you're able to talk, follow commands, instructions, that kind of thing. And then we're able to review it, and we'll actually, and you're there,
Yeah.
we actually see the videos and kind of break it down piece by piece and look at all the ancillary testing we do as well.
I think one of my favorite things about the videos is when they ask them to remember a series of words, and the words that they come up with are silly and very interesting. And
Like,
but it's
pink elephant or
yeah, 3 blue roses. But it's good. It's to test memory.
Yeah. And we have examples here, generic MRI, we start off with that, if there's a lesion, meaning like a tumor or any area with like scarring or anything that you can go after, the chances of you becoming seizure free are higher. You have an area, if it's an area that you can take out, you do it, great. But usually the cases here are not that simple. So we start with that and we do all the rest of the steps that we discussed previously. And that's what the fMRI looks like. And here we have the PET on the right side, and you can see that area that appears down. There you go. That kind of lines up with the area in the syscom that's lighting up, which is actually the subtraction of the other two superimposed on the MRI. But you see how it's like putting together pieces of the puzzle. And I think that's like the challenging but very rewarding part of the job, because I like the team aspect, and it's really like a puzzle. So then after that, if we determine that we can do surgery or whatnot, we do. But many times, like I said, our cases are complicated and we may need more. So that's when we may proceed to a phase 2. And that means like directly in the brain. Nowadays, a lot of it's being done intracranially, like stereo EEG. And Dr. Lega, our neurosurgeon, uses a ROSA a lot. Think of it like a robotic arm with like GPS to help them guide the electrodes in the brain, wherever we hypothesize that they need to be, because their seizure generators could be in those areas, right? And you see they drilled little holes in the skull and where they're placed, and then they get connected, they come up to the EMU, reconstructed, whatnot. There's a picture of him, a tiny picture, and our clinical neurophysiologist extraordinaire, Dr. Podkoratova.
Yeah. She's great.
And then we do the same thing, bring them to the EMU, taper, wean off meds, record seizures safely. But this time it's more precise because it's in the brain. And then once again, we meet and we discuss it and we try to put it together, right?
Yeah.
I have not discussed the MEG because even though we work together, I want to leave it to the expert, and Dr. Davenport will take over. But this is a tiny picture. We haven't taken a recent picture because pandemic, yeah. But this is like an old picture of like most of our village, the epileptologist, and I love it. But a lot of us aren't there, like the technologists and the nurse practitioners and whatnot. But
when I started going to conference, I was amazed at the number of different disciplines that come in to help, and like every case gets like scrutinized, a lot of attention to every case, meaning every patient is very scrutinized, every detail. I love working with you guys.
Like neuroradiology, you're there, neuropsychology, neurosurgery, psychiatry, all the trainees. I mean, everybody's there.
Yeah, it's really great. It's like great, meeting of the minds.
There you go.
All right, so I'm going to talk about MEG. And so, oh, whoops. Well, here we go. So I'm going to give you a tour. So we're actually sitting in the MEG suite right now. And this is what it looks like. So normally we would maybe have you here and give you a little tour. The other doctor there with me is Dr. Proskovic. She's another one of our MEG scientists that works with the team. She's fantastic. And she just joined us as faculty 2 months ago, I think. And
That seems like forever.
it seems like forever ago. Yeah, time is weird in the pandemic, at least. So first, I'm going to talk about magnetic versus electric fields. So what you heard about was MEG earlier, or sorry, EEG earlier. And EEG is, like we said, measures the electrical conductivity. And so here you get the electrical signal and it goes through all these different tissues, but it can be misleading because it can come out of the different tissues further away than it is from the source. So you don't have a good precision with where it's going to come out. And so, but those electrical fields also make magnetic fields. And this is true if you remember or from high school physics. If you have an electrical current, you have a magnetic field that wraps around it. So here's this example where they're turning on the electricity in this wire, and you can see the iron shavings making a circle around it, showing you, visualizing that magnetic field. Well, that also happens in the brain. When the neurons fire, they have these ionic currents that go through these electrochemical gradients. Your synapses are firing, and it also produces this magnetic field. And that's what we want to measure. And so it can actually come outside of the head, and it travels really cleanly. So you have all of your neurons line up together, and they all send a signal all at once. They're all thinking as a group, so to speak. And they all send this very nice magnetic signal. And if we go back to our other example, this magnetic field travels really cleanly through the different tissues. So we don't have to worry about it getting skewed or bouncing around and coming out at a misleading location. We know that where it's coming from better. So what I'm telling you is that telepathy is real. If you stand close enough, you can, sorry, we won't get close, it's pandemic. If you stand close enough, you can talk to someone with magnetic fields, but that's not true. So the brain's magnetic field is on the femtotesla scale. This is 10 to the negative 15th. It's a trillion times smaller than a magnet you're going to use on your fridge. And additionally, the magnetic field decays at an exponential rate. So the further away you get from the brain, the less and less field you're going to have, and it's just going to plummet exponentially. This is kind of like trying to find a needle in a haystack, trying to find this signal. Another good example is trying to find a submarine in the ocean. So in World War II and during the Cold War, we always wanted to find the submarines in the ocean, right? Because they were kind of these hidden missiles that might attack the Navy ships. So the Earth has its natural magnetic field, the North Pole and the South Pole. And as the planes would fly along, they would actually have these magnetometers, meters that would measure the magnetic field. And as they flew over the ocean, they would see this very nice magnetic field. But then when they flew over a submarine, you would actually see this abnormality in the magnetic field telling you that there was a submarine there. And our military still uses them today. And so the brain scientist had a meeting with these actually geophysicists and the military and said, okay, you're measuring these magnetic fields from way up, and it's this tiny signal by the time you get up into the sky where the planes are flying. We want to do something similar, but in the brain, which is just an odd meeting of different disciplines that made this. And so what they came up with was the superconducting quantum interference device, very informally known as the SQUID. And that is what Dr. Cohen put into his new device that he called a MEG. and they made the first measurement in 1971. I think it was actually 1968, but they published it in 1971. And here you can see this is somebody with their eyes open, and then when you close your eyes, your amplitude goes up. Just like EEG. And so now we have a non-invasive technique for measuring the brain activity at a millisecond time scale with a lot of precision. So my next question for you guys is going to be, why is there this weird steel room around the sensor? So we're going to do a poll. What is the metal room for? To keep out noise so the patients can sleep, to keep out magnetic and electric noise, or to keep the ghosts from interfering with the signal, which is actually a real problem in our MEG suite. We always joke that the ghost, there's something in here that makes the computers go wacky sometimes. So when something won't work, that's our excuse. It's the ghost.
Spending too much time here.
Probably, yeah, that too. All right. Looks like we got about 60%. Getting there. I like that some people are voting for the ghost. It's a real problem. All right. So 93% of you are correct. It keeps out the magnetic and electric noise. An additional bonus is that it kind of keeps it quiet in here in the machine so that the patients can sleep while we're doing their test. All right, so stop share and click out of that. Okay, so this is called a magnetically shielded room. It's made up of mu metal that diverts the lower frequencies, and then aluminum that diverts the higher frequencies. So there is actually some basis to putting a tinfoil hat on your head to keep the aliens out. I wouldn't recommend it though. I'm not sure how well that actually works. So that's actually what this is made of. And this looks a little bit Star Wars-ish, a little bit scary, the first one that they used. Ours today looks a lot nicer. It's very white. The door is extremely heavy because it's made up of a couple tons of these different metals. Mu metal is actually only produced at 2 places in the world, so you have to special order it from Germany. And the Germans were very excited when they came to try brisket. They loved it. They loved it. They were thrilled. So
They came to deliver it and try the brisket.
Yeah, yeah. They were like, anytime there needs to be another installation in Texas, they were going to be here. So our modern MEG looks a lot nicer too. So we have 306 squids, not the animal, but the sensor. And they sit around the head like this, kind of in a Darth Vader shaped helmet. And then each of those sensors give us a tracing. And that is what Dr. Alick reads. And so when she reads through, she'll come to a spot in the study that there is an epileptic spike, something that an abnormal firing in the brain, essentially. And so she will highlight that for me and say, okay, I want to know where this is coming from in the brain. And so what we're going to do is we're going to do something similar to what the GPS locators do when you're trying to navigate your way around Dallas. Your phone is going to send a ping a signal. I'm not having a stroke, I promise. Your phone is going to ping a signal up to the satellites, and then those satellites are going to all talk together and geolocate where you came from. So if it tells you that there's bad traffic at 32.8 degrees north and negative 96.8 degrees west, sorry, I don't know how to read GPS coordinates. I should have looked that up beforehand. It's going to be a little confusing, right? You're going to say, okay, great, there's traffic there, but what does that mean? So you want to know the structures that you're around as well. So now that I've overlaid it with the street maps, I can tell you that it's on I-35 East near the Inwood exit. And so we're going to do the same thing, but with an MRI. And so this is my MRI. It's scrolling through from top to bottom.
It's your brain.
That's my brain. See, she's going to read it now. There's going to be some concerns.
Yeah.
So, and then we can actually reconstruct it in 3D. So this is my self-portrait. And now we know the shape of not only the patient's exterior of their skull, but the brain as well. And so then what we're going to do when they come in for the MEG is we're going to digitize the shape of their head. And so they wear these really cool glasses. The machine was designed in the 80s. It's been upgraded since then, but the fashion has not yet been upgraded. So you get these really nice glasses. And then our lovely tech, Jennifer, is going to go through and make a shape of your head. And it's going to look something like this.
So those are my brain parts.
And so that's me. And then we're going to overlay all of that together. So we have this 3D picture of your head. We know where the brain is. We now know where the sensors are because we plug those wires into the machine. And we can put it all together. So now I know where the satellites are. I know where my streets are, and I can tell you where the traffic is coming from. And so we do that using a very advanced mathematical algorithm. It's also known as beamforming or source localization. I would love to tell you all about this, but for the purposes of tonight's presentation, yeah, it's only Sunday.
Take forever and ever.
It's magic. It is computer magic for right now. So you'll have to trust me that I did enough training to know what I'm talking about there. And so the end result is this is that same spike that we saw earlier. And this is the one that was in the picture for the event. And here you can see that there's this activity right here in the brain, and we can watch that one more time really quick. And this is actually half a second of data displayed over 10 seconds. And so you can see that red, that's that extra activity. And so now we have a fun another poll question. And, somebody else already got it for me. So what area of the brain is this localizing to? So this is actually the most common area for focal epilepsy. We have the Lisa lobe, the foramen magnum, or the temporal lobe.
So somebody picks mine.
Yeah. When we were making the questions, Dr. Alick suggested the Lisa lobe. All right.
It was late at night.
It was.
I was so tired.
Yeah. We were doing our night shift.
Darn, not a single one.
Not a single one for yours.
That's okay.
That's all right. All right, so we've got 91%. It said the temporal lobe, that's correct. The foramen magnum is actually Latin for big hole, and that's the hole at the base of your skull that the spinal cord goes through. And then there is the Lisa lobe, which is a celebrity of some kind. I'm an engineer. I don't.
Oh my goodness.
I don't get out.
I'm not that much older than you
I know.
are. Anyway. She was big in high school.
I didn't get out in high school. Studied. So this is what it looks like on a real patient. So this is an example of one of our recent cases where a patient came in, they actually had a seizure in the MEG. And here you can see the localization of that seizure. And as you can tell, it's a very small area of the brain that had a huge impact on this patient's life. And we were able, so Dr. Alick went through, read the whole study, was able to and we were able to localize this to a very small area of the brain, which was really exciting for this patient, for the idea that it's there. And so then, we take this back to the team and Dr. Alick, and they plan the SEEG. So here you can see this is for this patient, and they really concentrated the SEEG in that area where we saw that MEG activity. It just really helps, I guess, to better inform.
Yeah, to better pinpoint or target those areas that we kind of let them know, like lit up whenever we did the MEG and analyzed the MEG. And also, if we saw anything in any of the other testing and whatnot, and that's how we create the maps. And that's how we know where the neurosurgeon needs to place the electrode and whatnot. So,
yeah. And one of the things that I skipped in this presentation, but we also can have them do language tests or have them tap their fingers while they're in the machine and map those areas back as well. So it's kind of a map for the neurosurgeon that says, don't cut here. These are very important locations. Here's the area that is sending a lot of signal. And so that is about it for what we're doing currently. And I'm going to give you guys a sneak peek, 10 years in the future, probably. We are one of the only locations in the United States that have an optically pumped magnetometer room. So I told you about the squids earlier. That was a very cool advancement in science. In the last 5 years, they've made even more advancements, and we are able to miniaturize the MEG into very small sensors that are mobile. And so this is great for kids. We can give them a little helmet and they can kind of, where you still have to be inside of a shielded room, but you don't have to be in this big scary machine. And
Kids are wiggly.
yeah, they're very wiggly. That's one thing that I've learned is that with our techs are fantastic with the wiggly kids, and getting them to lay still for this exam. But hopefully with this new technology in the future, as we do trials with it and we learn more about its capabilities, we'll be able to use it on patients maybe in 5 to 10 years.
And that's another thing we didn't mention, like we scan kids here too.
Yes.
It's not just adults.
Yeah, usually on Mondays for anybody who's curious. But yeah, and then I think at this point we're ready for those questions. I know,
And hopefully we haven't lost any of you.
I don't think we've lost anyone, but I just want to say, first of all, thank you both so much. That was a fantastic and informative presentation. I, for one, learned quite a bit. So I'm just going to jump into questions because we've received quite a few. One of the questions I'm going to start off with was submitted for someone who registered when they registered. The question is, can a child outgrow seizures? And if so, how can a parent help the child outgrow naturally?
So yes, I'm going to start with yes. There's sometimes that a child can outgrow seizures. I would say the most common examples are whenever they have like simple febrile seizures, that they can have seizures in the settings of fevers, or usually around 5 months to 6 years old or so. And they don't necessarily need to be on meds and they'll remit fine. Or if they have benign epilepsy with sensotemporal spikes, like Rolandic epilepsy. And we know those syndromes you could outgrow and don't necessarily need treatment. Yeah, I would say those. Naturally, I would say just general, health.
yeah.
Yeah, exactly. I don't think there's anything that you should add to any regimen or vitamin or whatnot, as long as everything has been looked into and the diagnosis confirmed that it's one of the syndromes that you can outgrow and the neurologist should know. But if it's not one of those, you still have to be careful because you don't necessarily outgrow seizure disorders. It just in some cases.
Yeah, it depends on like the brand of them.
The brand.
Yeah, the brand. Yeah, and I like she talked about earlier when you were talking about like general health, like sleep, all of those things. That's one of the things that we ask our patients to do is to be.
Go to your PCP, take good care of yourself, good nutrition, good sleep, physical activity, take care of your mental and physical health. Yeah, all the goodies. So.
Great, thank you. Our next question comes from Tejasvi. Is there any relation between mental health and epileptic seizures?
Yes, absolutely. Bidirectional, I would say. Like I mentioned earlier, and there's a reason why I mentioned it, and I tell patients like this, a lot of people or most people that have seizure disorders will have a mental health comorbidity, mostly, a mood disorder, anxiety, whatnot. And I like to bring it up because if we don't address it, not only is it bad for quality of life, but it can negatively impact seizure control. They might not be as compliant with the treatment, that kind of thing. And also, poor mental health can also affect, seizure control and make it worse, and more seizures can lead to worse, mental health and vice versa. I hope that makes sense.
Bad cycle.
Yeah.
Because this is one of your areas of research,
Yeah.
right? Is into mental health and seizures.
I feel it's been long enough that hasn't been more of the focus, and it's like huge. So
Yeah.
Thank you. Our next question comes from Zach. Is a computer program monitoring and successfully detecting seizures as soon as they start and alerting the staff, or do the staff have to visually monitor continuously 24/7?
I wish. There are programs, Persist and whatnot. They're not great. You can fine tune them and whatnot, but a lot of them pick up a lot of noise. So I still prefer visual inspection and maybe using the FFT and whatnot, but they in no way are superior to actual read by an epileptologist. There's always EEG tech watching the monitors just to make sure, is that movement? Is that actually something epileptic? And then whenever the files get downloaded, if we're not there, and if it's during the night, then whenever we review, we actually go through every second. It's pretty time consuming, but I mean, it makes all the difference in the person's life, right? So that's what motivates us to do everything we do. It's many people working together. So
It is an area of research that we're
yeah,
working, but definitely not.
we're not there yet by any means.
Time consuming, but very worth the time. Next question comes from Melinda. If someone has a stroke, is it assumed that they are at a higher risk of having a seizure?
Absolutely. Especially in the adult population and elderly, it's one of the most common reasons for a person to develop epilepsy. Any injury to the brain will put a person at higher risk of developing a seizure disorder because it acts as a substrate for abnormal electrical activity. So yes, definitely.
Thank you. Next question. Can CBD or marijuana help with controlling seizures?
I knew that was coming.
Absolutely. You can never finish a talk without the CBD. Yes, it has been shown to help. What I always say is that it's best if we prescribe it, because there is a medication that's pure CBD oil that we know the exact concentration and that we can titrate and know exactly what you're getting so that it's not adulterated or other stuff in it. And it's been shown to help in certain seizure syndromes such as Dravet and Lennox-Gastaut syndrome, LGS. So it's approved for those and been used for others, but basically approved for those. And I mean, it does help in some cases. Some other times people are not able to tolerate them. And plus, it's a little, I get a little nervous because a lot of people just think they can just get it off the street and whatnot. Not everybody can go to a vape store and get CBD and whatnot. You don't know what you're getting and you don't want to put anything in your body. And plus, it's natural, but it'll hurt your liver. And if you're on medications like Depakote, clobazam, whatnot, or that'll hurt your liver. And that'll lead to bigger problems, and it'll make the levels of the medication hard to control. And I would rather, people be forthcoming with the information and let me help with that. But yes, CBD oil has been proven to help in some cases. And it doesn't make you high because it has to be really, really, really low tetrahydrocannabinol,
The THC.
the THC. And the Delta 9 THC, and it's higher CBD, which doesn't get you high.
Next question that was submitted ahead of time. How helpful are traditional oral medications?
They are very helpful. They are very helpful. Like I mentioned, there's over 30 medications on the market right now. Like everything, I mean, even Tylenol has side effects. Everybody responds differently. The big thing is to identify if a person has a focal seizure disorder or a generalized seizure disorder, because if you put somebody on that has an underlying generalized seizure disorder on a very narrow spectrum medication, you can actually make them worse. And that's why, especially that first visit, I like being really, really specific and like get all the details, and subsequent ones too, but especially that one to kind of like formulate in the back of my mind, like what I could be dealing with. So I don't treat them with the wrong medication. But yeah, no, you can do it monotherapy and drive up the dose or use it in combination or whatnot. But like I mentioned before, there's still a third of patients that will not respond. And that's why we do all we do. So.
Jumping back to the chat, a question from Andy. While patients are not actively seizing, can any imaging technique differentiate a person with a seizure disorder from a person without a seizure disorder?
Yes.
So if you count MEG as an imaging technique, because some people consider it like a recording, if there's these things called interictal spikes, which is between seizures that you would,
And that's what we see in EEG too.
right, yeah. So I don't want to answer for the physician.
I just don't know if I understood the question clearly. Can you repeat it again? I'm a little hard of hearing too.
Yes, let me find it. Okay. While patients are not actively seizing, can any imaging technique differentiate a person with a seizure disorder from a person without a seizure disorder?
Well, imaging, not really. That's what I wanted to clarify. Neurophysiologic studies may help because, like Dr. Davenport mentioned, EEG, MEG, whatnot, can pick up, any kind of regional focal slowing, rhythmic slowing, spikes, sharp waves, whatnot, that you may see in between seizures that may point to irritability that may generate seizures. But in like structural imaging, like MRI and whatnot, unless there's like an obvious lesion, I mean, a lot of our patients have unremarkable normal MRIs and they still have the seizure disorder. So no, it doesn't really eliminate the possibility somebody can have seizures, even if it's normal. Those are what we call non-lesional.
Yeah, the non-lesional, and then that's why they come to see us at the MEG, is that it's looking in and putting that all together with the structural.
How many MEG machines are in Texas and how many are in the US?
So Texas is actually special. There's 5. It's just everything's bigger in Texas. So there are 5 MEG machines in Texas. There's 2 in Houston, 1 in Austin, 1 in Fort Worth at Cook's Children's, and then 1 here. We are actually one of the only centers that specializes in adults as well as children. The other centers tend to cater more to children, which is great. And then in the United States, there's about 35, maybe 40 now that there's been a couple of new installations over the last year.
Yeah, because some of them are research and some clinical and whatnot. So
yeah, there's a little map online at the AC MEGs, American Clinical MEG. But so we also will get patients from Oklahoma and Arkansas will come and see us. So that's another thing that's exciting about the new realm of MEG, these smaller MEGs, because this actually takes quite a lot of space at the university, which is a hot commodity. And it was expensive. It was a lot to install. So we're hoping to make the technology more available in the future. Portable, yeah.
Paul asked, is the MEG ever recommended when medicine is working?
not really. I mean, It is a lengthy study, expensive study, and it's not really indicated unless you have drug-resistant epilepsy. There is no reason to really do it clinically unless you're trying to find the seizure focus. So,
Because it's approved for pre-surgical mapping.
uh-huh,
So if you're not planning on surgery, right?
yeah.
Yeah.
Just a couple more questions. Pega asks, how long is the minimum duration of acquiring the MEG signal?
So for epilepsy, we typically do around an hour. And that's because some people will have these interictal spikes all the time. And then sometimes they will, have 1 or 2 an hour. And so we want to capture as many of those as possible. In terms of research, we
And we
can,
want to capture sleep
true, that's important. Yes, thank you.
and research.
And for research, we do as short as 6 minutes. So we're looking at using this technology to maybe do an earlier detection of Alzheimer's disease, to better treat concussion, to better diagnose concussion so it can be treated in different ways, as well as autism diagnosis and testing treatments for autism. So there's a lot of different research going on. And so that is about, those scans can be as short as 5-6 minutes.
Nice.
Dr.
That hour seems like an eternity, but yeah.
Dr. Alick, when she reads the hour-long studies, I know she's cursing.
I get antsy, but
Yeah.
it's worth it, right?
I'm going to ask one last question because you just mentioned sleep. Alice asked, can a sleeping person have a dream while they're having a seizure?
Interesting.
Can a person have a dream while they're having a seizure?
Mhm.
I mean, I don't know the answer 100% for sure, but I don't see why a person can imagine something while they're seizing and they have altered consciousness. So I don't know if anybody could be able to answer that 100% certainty, but
It's interesting.
yeah.
Yes, thank you both for tackling all those questions so quickly. There were many more that we didn't get to address, but thank you both so much. Oh, actually, wait, one last one. Let's see. Jenny, do you see this question?
Yes. Have there been clinical trials with MEG? And what is the advantage of MEG over some other seizure medications or treatments?
Okay.
So the first part of it was, what was
Are there any clinical trials?
Are
with
there
MEG?
so there were clinical trials. This was FDA approved in 1993. And so now we are fully approved to use this for pre-surgical mapping. In terms of clinical trials, we are doing research in terms of other indications, but not on epilepsy. It's fully approved and fully tested for informing surgical mapping. And then I'll let you tackle the next part.
It's the only approved indication right now. And
Yes.
one thing that I want you all to leave this talk with is that please remember that the MEG is a modality, a neurophysiologic test to add to the presurgical workup of intractable drug-resistant epilepsy. It is not a treatment, okay? So it's whenever all of their treatments fail, it helps us come up with a management plan, whether that be an open surgery or laser, or if we can't do that, maybe we can do a neurostimulation device like BNS, RNS, DVS, or a combination or whatnot after doing an intracranial monitoring if needed. So, I mean, there's topics to discuss.
Yeah, the MEG isn't going to do anything to you. It's actually
Yeah.
completely passive. It's just listening to the brain.
Yeah.
So it's FDA approved for pregnant women, children. We scan babies as young as newborns sometimes for research studies. It's very safe. It's not doing anything. It's just listening.
There's really like close to no limitations or exclusions. So.
Yeah, there's no risk for doing a MEG. Did that help?
That is perfect. Thank you. And I think that's a great place to conclude. And I want to thank you, Drs. Alick Lindstrom and Davenport. This was fascinating to learn about how the MEG is a diagnostic treatment, how it's transforming lives, and helping you improve epilepsy surgery outcomes. And I think it's really inspiring to consider how healthcare is going to continue to be impacted by such innovative treatments and technology tools. Thank you to Terlandra and Joya for helping run our event this evening, and everyone, it is so good to be back with you. We hope you'll join us in 2 weeks on Thursday, September 9th for the Science of Food Allergies and the Impact on Children with Dr. Christopher Parrish. Following that will be another cafe on Thursday, September 23rd about prostate cancer, biomarkers, prevention strategies, and treatment innovations with Dr. Yair Lotan. And before we adjourn, as you know, we must implore you and your friends and family to get a COVID vaccine. Vaccines protect you from severe illness and death from COVID-19 and its variants. For information on COVID, including vaccine appointments from UT Southwestern, click on the yellow COVID information bar at utswmed.org. And if you're an existing patient who received your vaccine from us, check your MyChart account soon for booster shot information. And finally, even if you are fully vaccinated, please continue to help us by wearing masks, social distancing, and being vigilant with your hand hygiene. Let's put a stop to the variants and the breakthrough infections as much as we can. Thank you for doing your part to contribute to good public health. And for now, we wish you good health, good spirits, and a good rest of your evening. We are adjourned. Thanks for joining us.